Hey, Dr. Amanatullah, how are you doing today?
I'm doing great. Thanks for having me again.
Thank you for coming on again. We're going to talk today about dislocations with joints. So, first, just as simply as you can explain it, what is a dislocation?
So dislocation is when the hip joint comes out of the socket. So the ball separates from the socket. And this is a pretty nerve-wracking, despite not being that devastating complication that normally can be managed after a hip surgery. And it really comes because at the time of surgery, there's actually three goals that need to occur. You got to have the implants be fixed in the bone. They have to be fixed in the bone in the right position so that the hip won't come out of the socket or it doesn't impinge, means it touches anything else, either the metal or the soft tissues, so that it doesn't come out. And then we try and make your legs equal. So really dislocations can be caused by lots of different things, and they're really something we worry about a lot, but there's something that we can be managed if the components are in a really good position.
How often does dislocation occur? How worried should I be about that?
The dislocations are in general quite rare. The data would say they range from about 0.5% or even lower to around 7%. So there are some things that we do now to prevent dislocation. Some of those are the approach. So lots of people have cited the approach as decreasing the dislocation. But now, even with approaches that were at risk, specifically the posterior approach, some soft tissue repairs and how we handle the tissues have decreased that dislocation risk down to the point where we can't tell the difference across approach. So I'd say historically, the way the surgeon did your hip replacement made a difference. In modern hip replacement, it doesn't make a huge difference at all. There are some things related to the patient, meaning obesity, maybe utilization of narcotic drugs or other things might increase your risk of a dislocation. And then there are things outside of the patient's hands. The position of the components themselves can lead to them touching each other. And so you want to make sure you have a surgeon that you trust that's going to put the components in the position that's going to work and function correctly.
If my hip gets dislocated, I feel that like high intensity pain. What are my steps? What should I do? Who should I call? What do I do?
Yeah, so lots of people will talk about clicking or other things being a dislocation. They're probably not. What you want to imagine is that your hip has very large muscles around it, your quadriceps muscle, your gluteus muscle. And if the hip were to actually come out of the socket, those muscles would fire really hard to try and put it back in the socket. And unfortunately, because the ball will have slipped out of the socket, they'll actually push it out. And so it'll be, unfortunately, unbelievably painful and probably won't be able to walk. And so what I would say is this is not a thing where you would go and wait for a visit for your doctor. This is something you would go to the emergency department to get treated, because it's not tenable to have a hip that's short, rotated, funny, painful, and maybe not able to be walked on. The good part is that if this gets treated, about 2/3 of the patients never have another dislocation. But it is possible that it becomes a chronic issue, meaning you have more than one dislocation. In that case, we're going to have to pay really, really particular attention to the components to make sure they don't need to be changed, make sure there's no infection, and then we might need a surgery to do some extra things to the hip replacement to make it more stable.
Besides the things you mentioned earlier about, keeping your weight in check and not using narcotics, is there anything that I can do to make sure that my hip doesn't get dislocated?
I would say in general, there's not a lot of things that the patient can do, but some doctors, there's not a lot of evidence for this, will give you precautions. Precautions are places you shouldn't move your hip because they would place it at high risk for impingement or dislocation. And that the directions of those precautions really depend upon the approach. So if you had an anteriorly based approach, you're going to want to avoid extension and external rotation. What does that really mean? The time that extension external rotation really occurs is reaching above our heads to get something like a can of soup or something from a cupboard. What happens is we put our operative leg back, we pivot on that operative leg, and that can put us at risk for dislocation. So any anterior approach, you could consider not doing anything that placed your hip in extension. The opposite is true of a posterior hip approach. In any posterior hip approach, the way we take the hip out of the socket is flexion of the leg and internal rotation. So when does that occur? That occurs when you're sitting in a chair and an object falls on the ground and we reach to our side to pick up the object. That places the hip in that position of flexion and internal rotation. The other time it occurs is similarly sitting in, say, a deep sofa or a recliner chair with no arms. So most of us, the way we would get out of that chair is to squeeze our knees together. That's internal rotation. Lunge our body forward, and that's flexion. The other way that hips come out of the socket is normally with sexual intercourse. So the leg can be placed in odd positions, and the patient's not necessarily paying attention to protect those positions, and that can lead to a dislocation as well. There's some publications about that, about specific positions that are safer than others for our patients after hip replacement.
Awesome. Well, thank you so much for answering my questions today, Dr. Amanatullah. I really appreciate it.
No worries. Have a great day.